This concise video log on using HIV-ASSIST to support ART selection in a patient with multidrug-resistant HIV was pre-recorded by Dr. Natasha Chida. This activity is provided by Clinical Care Options as a CME-certified activity on the Clinical Care Options website. This program is supported by independent educational grants from Gilead Sciences, Theratechnologies, and ViiV Healthcare. Dr. Natasha Chida is an assistant professor in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine in Baltimore. This vlog is part of a comprehensive educational program on using HIV-ASSIST as an educational resource for selecting ART in patients with HIV. You can obtain downloadable slides on the Clinical Care Options website, as well as gain CME, CE, or CPE credit by viewing this vlog.
Hello, welcome to this video log using HIV-ASSIST to support antiretroviral selection in a patient with multidrug-resistant HIV, including high-level integrase inhibitor resistance. My name is Natasha Chida. I'm an assistant professor in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine, and I don't have any relevant conflicts. So I wanted to discuss with you all a complicated patient that I saw in clinic who's a good example of the difficulty we find ourselves in when trying to select an antiretroviral regimen for someone who has high-level integrase inhibitor resistance. So this was a woman who was 48. She was diagnosed with HIV in 2002, but didn't start on any therapy in 2012. And after that time, when she started, she had a history of intermittent ART adherence, primarily due to substance use disorder and depression, and had been on multiple regimens before she came to my clinic. She had had many years of treatment at other facilities, and so I didn't have ready access to a lot of her data. And when she came to clinic, she was viremic and did actually say that recently she hadn't been taking her medications every day and had been missing maybe 3 days or a week or so. You can see that when she presented to clinic, her initial CD4 count was 7, and her viral load was 65,700 copies. And we'll go through her genotype in a bit, but she had multiple resistance-associated mutations. I did not know what her tropism status was. We knew she was hepatitis B and C negative because of recent testing that we had access to. And we knew that she had a negative HLA-B5701 status. At the time of coming to clinic, she was only on buprenorphine. And again, her primary comorbidities were depression and substance use disorder. In terms of her substance use disorder, it had actually been in remission for several months by that point, and she was feeling really happy and confident and optimistic about her ability to stay off substances in the near future. And her depression as a result was also doing much better. She was in a much better place. And so we were able to gather some of her prior data from the facility she had been, but again, there are some holes in what we have access to. But you can see that the highest her viral load goes when she's not on ART from 2007 is into the 100,000 range. And then you can see the prior regimens that she had been on. At some point, she was on raltegravir combined with efavirenz, tenofovir, and FTC. And then she'd appeared where she was off of ART for some time. And then after that, she was intermittently on dolutegravir combined with tenofovir FTC until 2018, when she was trialed on dolutegravir and rilpivirine, with a thought being that perhaps with a reduced pill burden and with a small pill that she would do better. And so you can see that up until 2018, she only has a few genotypes that we have access to or that were drawn. And you can see that in 2017 and 2018, she has wild type virus, despite having had prior episodes of intermittent adherence. And I think the reason that we're seeing wild type here is not because she doesn't have resistance mutations, but we don't think that she was actually taking her regimen at the time. You can see that her viral load is in the 100,000s, which I think is probably the highest her viral load goes when not on ART. And so because of the fact that she wasn't taking her antiretrovirals at the time, what we'll see on genotypes is wild type virus as opposed to underlying mutations that would come out more under drug pressure. So because of the complexity of this case, she's a great person to consider the HIV-ASSIST tool. And so I put her case into HIV-ASSIST. I included the resistance mutations there, as you can see. And upon discussion with her, she really thought that one of the barriers to her taking her meds is when she has to take them multiple times a day. She really thinks that taking drugs once a day will help her a lot with her adherence. So I selected that as an option, as you can see there, and also noted that she had a history of intermittent adherence. Her viral load, as you can see, is low level. She's 65,000 or so. Her CD4 count is quite low in the single digits. And we can input here her HLA status as well as her tropism status. And as you can see, we can also include her comorbidities and other medications she's taking, as well as prior regimens that she had been on and had failed, and her current regimen. I'll note one really nice aspect of the tool is this ability to include prior failing regimens, even if you don't have known genotypes at the time, because the tool will then note that this person was viremic on these drugs, and therefore there may be concerns about resistance there. Once I put that in, the tool actually prompted me to clarify one of the mutations. So there are some overlap mutations that have the same name, but are in different parts of the virus. And so the mutation here, the E138T, could be either a reverse transcriptase mutation or an integrase mutation. So the tool prompted me to select which one it was, and it was an integrase inhibitor mutation. So here you can see the output of HIV-ASSIST after inputting all the information we described before. And I want to highlight what's noted at the top, which is that this is a patient who is going to need a salvage regimen for her care. And so what the tool will mention is, because you're considering a salvage regimen, you should consider seeking infectious disease consultation, or you can actually start a discussion with the National Clinical Consultation Centers through HIV-ASSIST itself, as there are partnerships there. And so because this is a patient who is not straightforward, who you need a salvage regimen for, there is support offered through the tool if that is of benefit to you. And so you can see here, the drugs that are coming up at the top are several combinations. One is ibalizumab combined with boosted darunavir. And then you can see below, there are even options that include AZT, as well as other regimens. I'll note that actually in the beginning of inputting her case, AZT was automatically selected to not be included because the tool allows you to choose drugs that you don't want to include. However, you can see here that the system actually overrode the exclusion of AZT because this patient has so few options and it needs a salvage regimen. So the tool is basically telling you, hey, even if you don't want to use AZT, it may be something to consider here because it has lower weighted scores and penalties compared to some of the other regimens. And so you as the user, of course, can take that information and do what you like with it. If you still don't want to use AZT, which I didn't, and I'll discuss soon, you don't have to, but the tool will let you know if some of the drugs that you want to exclude may actually be of benefit. And so I discussed the options with the patient, and she actually, I initially thought that she might not want to do ibalizumab. It's an infusion. She would have to come to the clinic twice a month for it. But she actually really liked the idea. She thought that by kind of forcing her to come to clinic, it would help her be engaged in care. It would help her be engaged with the clinic, and it actually would help with her adherence. So she really liked the idea of ibalizumab, which was great. We also enrolled her into a directly observed antiretroviral therapy program that we have access to in our clinic, which is a really wonderful resource where people will actually visit the patient and watch them take their medications as a way of promoting adherence. And she really liked that idea as well. We discussed the drugs that had come up in HIV-ASSIST. And while she liked the idea of ibalizumab, when I discussed the side effects of AZT with her, she was concerned. The main things that worried her were the side effects of headache and myalgias, as well as anemia. The prior two really worried her because she thought they might remind her of going through withdrawal, because those were some of the symptoms she had when she did experience opioid withdrawal. And she was just nervous about experiencing something similar again. And then in terms of the anemia, the idea just made her really worried. She had family members who'd had anemia and had some poor symptoms related to that, and she just didn't want to do it. And so she deferred AZT as an option, but again, was interested in ibalizumab. So at the time when I was seeing her, you can see here in the output, I've crossed off the regimens that include AZT because she didn't want to take it. And here you can see our options now are ibalizumab basically combined with one or two other drugs. And you can see here that these are all high weighted scores, again, implying these are salvage regimens. And which one to choose is going to be very much dependent on patient preference, as well as what the provider is concerned about. It's much less straightforward than some of the other cases we discussed. And so in terms of what we chose upon discussion with her, I'll note that thinking about the mutations that she had, you can see here that one of the benefits of HIV-ASSIST is that it incorporates mutation data from the Stanford HIV drug resistance database. And so if we go through the mutations that she has, you can see that she has fairly high level NRTI resistance. The red boxes here denote the mutations that she has, and you can see the penalties for each of them. So she's pretty high level penalties to 3-TC, FTC, as well as tenofovir in the 50s to 90s range. And you can see here that actually AZT is very active. The score is -25, but again, she did not want to take that medication. And then if we look at her NNRTIs, again, the red boxes denote her mutations. You can see that she has fairly high level resistance to efavirenz, etravirine, rilpivirine, and nevirapine. But actually her doravirine resistance was a bit lower than the other NNRTIs that were available, with a total score there of 25. And so I'll just say that, when I have had patients with multi-drug resistant virus, often the agents that we turn to are including protease inhibitors and integrase inhibitors. But this was a patient, and one of the first I've seen in a while, who had very high level integrase inhibitor resistance to all the agents that we had access to. So you can see here with her mutations, each of the integrase inhibitors is fairly highly compromised and not good backbones for a regimen for her. And so we were moving towards a regimen that did not include any integrase inhibitors. And so another nice feature of the tool I want to comment on is I was considering a regimen including ibalizumab. And so when I actually selected a regimen that had ibalizumab from my output, an education sheet popped up, which actually summarized the primary trials that led to ibalizumab approval. So in real time, I'm able to look at the data that supports the regimen I'm considering and see how does this pertain to my patient? What are the similarities between patient populations, et cetera? And so in real time, I'm getting high level literature that's helping me make decisions. I just want to talk briefly about ibalizumab itself and the trials that led to ibalizumab being approved. So ibalizumab, as many of you know, is a humanized IgG4 monoclonal antibody. It's an entry inhibitor and binds to host CD4 cells, and so prevents entry of HIV into the T cell. In terms of the trials that were employed to examine ibalizumab, they're a bit different from other typical HIV drug trials because the drug trials that focus on people with multi-drug-resistant virus are really focused on an efficient assessment of safety and efficacy in people who don't have many other treatment options. The concern is that these are patients with such high-level resistance and very few options that they have a high risk of mortality and morbidity in the short period of time. And so the trials really try to focus on getting answers very quickly as to whether or not these agents could be beneficial for patients who don't have any other options. And so that leads to some key difference with other HIV drug trials. These tend to be smaller trials, and that are commensurate with the population of patients with MDR HIV in the United States. They tend to have different efficacy standpoints. So in these trials, and in the trials that we're going to talk about, the primary biological efficacy assessment was 7 to 14 days after the agent was added to a filling background regimen. If you compare that to other drug trials that look at new agents in people without resistance, typically it's a much longer time to evaluation of virologic efficacy. And then the other thing that's a little bit different is after the primary efficacy endpoint is examined, patients then have their regimen changed to an optimized background regimen based on their individual resistance profile. So you end up getting very heterogeneous regimens being used in the trials because patients have very different profiles. So unlike other HIV drug trials where people are getting the same thing throughout the trial, in these types of trials, people are getting very different regimens as a result of their unique resistance patterns. And in this trial, the efficacy and safety analysis was conducted at 24 weeks, rather than the typical 48-week assessment that we see in other drug trials. So really the summary here is that the trials that are used to examine agents for patients with multi-drug-resistant HIV tend to be smaller, they tend to be conducted with less time to follow up, and their efficacy endpoints tend to occur earlier than in other types of drug trials. So let's talk about TMB 301, which was the study that led to the approval of ibalizumab for multi-drug-resistant HIV. So this was a single group open label trial that was phase 3 of 40 patients. So again, getting back to the idea that these are smaller trials. In order to be included, you had to be an adult with HIV who was on antiretroviral therapy for at least 6 months. And you had to have a viral load of at least 1,000 copies per milliliter with at least 3 class drug resistance. But you needed to have at least 1 remaining active drug, even if it was an investigational drug. The primary endpoint in this trial was the proportion of people who had at least a 0.5 log decrease in their viral load after ibalizumab initiation. So again, very different primary endpoint from what we see in other drug trials. And so the design is unique here because what you're looking at is adding an investigational agent to a failing regimen and then eventually switching to an optimized background regimen. So the way the trial worked was that people were maintained on their failing regimen for about a week, and then ibalizumab was added to their regimen, and they were followed for another week or so. And that's when they met primary endpoint analysis, meaning did ibalizumab being added to their failing regimen lead to a reduction in viral load? After the analysis, they were then switched to an optimized background regimen and were maintained on that up until day 21. And after that, they just had a secondary endpoint analysis at week 25 of being on an optimized background regimen combined with ibalizumab. So let's talk about the baseline characteristics of this trial. The median age of patients was 53, and the majority were men. 55% were white, and the median CD4 count was 73 cells per millimeter cubed. The mean HIV RNA level was 4.5 plus or minus 0.8 log 10 copies per milliliter. And actually about 18% of folks had a viral load of at least 100,000 copies per milliliter. 68% of the patients in this trial had integrase inhibitor resistance, and 90% had PI resistance. So if you think about our patient, she has significant integrase inhibitor resistance, but she actually has full activity of protease inhibitors as far as we're aware. She's similar to this trial in a lot of ways, with one exception being her ability of using PIs. So the results of the study, out of the 40 patients, 31 completed the study, 9 didn't. Of those, 4 had died. 1 was withdrawn by their provider, 1 had an adverse event, and 1 did not adhere to the study drug regimen, and 1 withdrew. And so again, you have a fairly small population that you're studying here. On intent to treat analysis, 83% of the patients met a primary endpoint of a 0.5 log 10 decrease in HIV RNA level, at least, 7 days after the initiation of ibalizumab to their failing regimen. And this was statistically significant compared to the viral load they had prior to ibalizumab being added. And then in terms of their week 25 data, when patients had been switched to an optimized background regimen combined with ibalizumab, you can see that they had a mean decrease of 1.6 log 10 copies per milliliter. And of the patients, actually 43% had obtained an undetectable viral load of less than 50, and actually 50% had a viral load of less than 200. Of the 10 patients who experienced virologic failure during the trial or virologic rebound, 9 of those people had decreased susceptibility to ibalizumab. And so we talked through the results of the trial with the patient. And I sort of highlighted that the drug trials that lead to the approval of agents for salvage regimens are a little bit different from typical drug trials. And so while certainly ibalizumab from the trial is beneficial for her particular situation, both of us felt a little bit nervous about ibalizumab just combined with one other agent. We just didn't feel like there was a lot of data. And she was kind of feeling like this was going to be her last best chance. This was a period in her life where she had been off of opiates for a prolonged period of time from her perspective. And she was just worried that if she didn't take her chance now, and we weren't as aggressive as possible with treatment of her HIV, that she would fail. And so both of us decided that perhaps a third agent would be a good idea here. Again, not based on data or based on any of the trials. And so we talked through the options. Again, remember, she did not want to be on AZT. And at the time, looking at her mutation penalties, it seemed that doravirine might be the best choice. It was a once-a-day option. It wasn't very big. And while there was resistance, it had a lower mutation score compared to the other agents that were available. And she actually didn't feel like number of pills was that big of an issue for her. Again, she just didn't want to take it more than once a day. And so we put her on ibalizumab boosted darunavir combined with doravirine. I will say that since I saw this patient and we initiated this regimen, we've now had access to results from the Nadia trial. And while that trial doesn't directly pertain to her particular clinical scenario, because in that trial, patients had full activity of integrase inhibitors and protease inhibitors, that trial did show that even in the setting of high-level tenofovir resistance, that tenofovir may have some virologic benefit to patients. And so now that we have access to that trial, I am considering whether or not TAF-FTC might be a better option for her over doravirine, because we do have a little bit of data now on using TAF-FTC in the setting of high-level NRTI resistance. Although again, in that trial, patients also had activity of integrase inhibitors. I'll note that actually, when I used the tool back when I was seeing this patient, And when I use the tool now with the same clinical scenario, we actually see different outputs because the results of the NAUGHTY trial have already been incorporated in the tool, which I think highlights how the tool is being adjusted and updated in real time based on data as it becomes available to clinicians and providers. So what are our take-home points from this case? So in a small open label study of patients who were heavily treatment experienced with high level resistance to 3 or more drug classes, ipilimumab produced a reduction in viral load 7 days after being initiated and added to a failing background regimen. And then week 24 of treatment with ipilimumab and an optimized background regimen, half of patients were actually able to obtain a viral load of less than 200 copies per milliliter. And I think the other take-home point is that HIV-ASSIST, particularly in this scenario, was able to bring together many clinical resources that informed my selection of antiretroviral therapy. It incorporated primary literature, guidelines, the Liverpool database on drug interactions, as well as the Stanford database. And so for someone like this patient who has a heavy treatment experience, high level resistance, including integrase inhibitor resistance, the tool was particularly helpful. But I'll note again that the tool will prompt you to consider a consultation with an infectious disease provider in situations like these, and if needed, can connect you to experts through the tool itself to have further discussion about options. So thank you very much for sharing this case with me. It was a more challenging one for me, and I hope that we all learned a great deal from it. Please remember to check out hivassist.com, which has been a really fantastic resource for clinicians treating people with HIV. Thanks.